இனிமே இதுல இருந்து தான் ரெக்கார்ட் ஆகும். யூடியூப்ல லைவ். இன்னி போனா பிரச்சனை இல்லை.
ஓகே ஓகே ஓகே. உங்க ஸ்டூடண்ட்ஸ் மறுபடியும்
இல்ல ஜாயின் ஆகி தான் இருக்காங்க.
நல்லா பார்க்கிறேன். A warm good morning to one and all. Welcome to today's presentation of concept of brain death from clinical and legal point of view. It's my immense pleasure to introduce the speaker, Mr. Karthik. Welcome, sir.
Thank you, ma'am.
He completed BSc Nursing in the year of 2009 in Vinayaga Missions. He worked in KMCH as ICU nurse under Dr. M.N. Shivakumar. He completed MSc Nursing Psychiatry specialization in our PhD in the year of 2013. He worked as clinical nurse specialist and a transplant coordinator in gastro HBP department in our hospitals under Dr. L. Venkatakrishnan, sir. He worked as the organ transplant coordinator in KMCH under the guidance of Dr. S. Vivekanandan. He coordinated more than 100 cadaveric and live donations. Currently, he working as a operations manager in RPS Hospitals, Chennai. Sir, now the session is yours. Please take over, sir.
Thank you, ma'am.
Okay.
அந்த யூடியூப் லிங்க் சரி அதுக்கப்புறம் கொடுத்தாலும் ஒன்றும் பிரச்சனை இல்லை.
Hello, good morning, everyone. I think I'm audible.
Yes, sir, it's audible.
Yeah. Hi, students. Like I'm Karthik. Currently, I'm in RPS Hospitals, Chennai. I'm taking care of clinical operations. So I was there in your place in PhD from 2011 to 2013. Actually, it's an awesome place to learn. The campus is amazing. The teachers are very good, and the clinical experience you won't get anywhere else. You know? And then I got a chance to work there with Professor Dr. LVK, L. Venkatakrishnan sir. I think you would have been seen in clinical postings. So there I learned, this about this brain death and started coordinating transplants. So then we moved on to KMCH and now I'm here. So seen a lot of brain death and transplants. So today it's my pleasure to be here, in front of you to talk about all this. We were taking, when I'm studying MSc, we were taking classes for third year BSc side around still. That was a very good experience. So I like to stand in front of you and talk, but unfortunately, we were not able to do this, and we are doing, online. So let's. So my topic today is brain death from clinical and legal point of view. So in generally, death abdina what we think. So general public think death abdina only when the heart stops and there is no respiration. So அதுதான் காலங்காலமா death அப்படின்னு இருந்துட்டு இருந்துச்சு. Still the general public think that's the only death. But only medical fraternity knows there is something called brain death also. So we people derive this brain death for some reason, and now it has been a very good thing that we identified this, and this is helping a lot of people who requires organ transplantation. So the discussion today going to be what is brain death, the history, a short glimpse, and how to diagnose, who is going to diagnose this, and what nurses are going to be doing in this. and the legal formalities and legal issues which we face. So definition. So definition, as I said, there are two aspects in this. So one is whole brain approach, and another is the cardiopulmonary approach. So this is the whole brain approach. So in this whole brain approach, even there are two things. One is whole brain approach, and also another one is brainstem approach. So whole brain approach, the US people say that, and brainstem is UK people derive this. But both are almost same. See, in this picture, there are three images. The first image is normal conscious person's nuclear brain study. This is so. Second one is a cardiac arrest, and third is a brain death. So in this nuclear study, they like instill some sugar, like so this is an normal conflict. You see, there is no activity in the brain. Complete approach as well. When the ECG they became flatline, so we say that is cardiopulmonary death. So next is the historical. So prior to the advent of mechanical respiration, means the ventilator, there is only the normal after ventilator has invented, so we could be able to do the circulation and keep the circulation alive, but not the brain. So very first it was brain death was identified in Paris, and it was named coma di fase, which is beyond coma. So they identified this in an hereditary patient with intracranial bleed. So after that, in 1968, there is
irreversible coma, brain death, with Harvard Medical School, they have given some guidelines. And after that, in 1981, there is another set of guidelines have been come, and in 1994, another in 2005. So if you talk about history, there is a lot of milestones in this, you know, like telling everything is difficult in this, why it's highlighted 4 5 points here. The next one is we have to know the basic anatomy of this brain stem. So why it is very crucial. So it has the midbrain, pons, and medulla, and it contains the nuclei of last 10 cranial nerves and ascending and descending tracts. So reticular formation, which is RF, is a complex network of nuclei and interconnecting fibers. The RAS provides an anatomical and physiological basis of wakefulness. The medullary reticular function is responsible for a heartbeat and circulation, and the pontine reticular function is for coordination of acoustic, vestibular, and respiratory and cardiovascular process. The midbrain reticular function is visual-classical orientation and eating behavior. I'm very sure by third year you have been learned all this, and you will be much better to tell me about brain and brain stem. If I have been there in front of you, I would have been asked about this. And why? What is the cause? Pathophysiology of brain stem. Why this happens actually? So I have seen most of the cases, in trauma. Trauma happens and RPA happens, and patient arrives with a casualty, and also CT shows. So Chandani. Hello. Am I audible? So the causes and pathophysiology of brainstem death. So here I think might be trauma. So in trauma, if you see, uh, so if there is a bleed and if it is compressing the brainstem, can cause brainstem death. Or else in bleed, in hypertensive bleed, there also it can cause brainstem death. So even a small lesion sitting over there, it can cause an brainstem death. So we should be able to identify why it is happening. See, the core of brainstem is consciousness. So respiratory is controlled in that, BP, heart rate, and your motor sensory impulses. Everything is controlled by your brainstem. So how will you identify? What are the practical things by which you can identify? So that's what we are going to see in this. So it is by initially by clinical evaluation. So what are the prerequisites we should know? And second is by neurological assessment and ancillary test, and also documentation. So prerequisites is initially we should know whether a patient is coma. So any CNS depressant drugs is on, like it might be alcohol, it might be any relaxant or any electrolyte imbalance can be there, acid-base balance, endocrine disturbances, and next is temperature. So temperature is very crucial, which is important. So I have seen many a times people missing out this. So they say everything is okay, we can go ahead for organ donation or apnea testing, and like usually I have a checklist. So when I go bedside and see that the temperature will be hypothermic. So then, obviously you have to rewarm the patient. It takes a lot of time. So you should, the nurse should know. So nurse should know all this. So only then we can check, the temperature and everything. So then the systolic blood pressure should be normal. So all these things. So there should not be any there should not be relaxants or sedation going on. Electrolytes should be okay. Temperature should be okay. Blood pressure should be okay. You should know the cause. Only then you can go to the next thing, which is neurological assessment. So in the neurological assessment, first thing is you should identify if the patient is coma. So coma, you can't just say coma. So there must be some scale or something to identify that. So that is a Glasgow coma scale. So you give a deep painful stimulus somewhere in the sternum or in the nail bed or in the supraorbital ridge. So then you score it. So if it is 3, then it is perfect. It is complete. The patient is complete coma. So the second thing is you have to check for the reflexes. So in the reflexes, first reflex is the pupillary reflex. So pupillary reflex. So it is generally everyone checks this in the neuro ICU or patient with some brain injury, some brain pathology. Neurologist and nurses often check this. So hourly there will be in the ICU chart, even hourly there will be a column for pupillary reflex. So normal people should constrict and dilate to a straight beam of light on it. So if there is no reaction to it and it is completely dilated and fixed, then it is due to a brainstem death. And next thing is a corneal reflex. Corneal reflex, you can take a swab and place it near the patient's cornea. If the patient blinks, then it is normal. If doesn't blink, the reflex is absent. The third one is an eye movement. So eye movement, oculocephalic reflex. So it is a dorsal movement you can check. So when you turn the patient at this side, the eyeball should move in the opposite direction. That's a normal thing. But if it doesn't happen, then there is something at this reflex is absent. And the next one is oculovestibular. So in this, we instill cold 50 ml of cold water through the ear. So when it touches the tympanic membrane, what happens is the if you instill cold water, the eyeball should turn to the opposite side. Warm means to the same side. That should happen. If that is not happening, then the reflex is absent. I'm very sure you would all studied all this. Neurological examination should have been practicing in the ward. But to make you understand all these are necessary, I'm going to these slides. So patient sensation and motor response. So if you give a painful stimulus, there should be some reaction. Even if you press the orbital ridge of a comatose patient, there will be some reaction to the patient. But for the brain death patient, there will not be any reaction. So next thing is a pharyngeal reflex or the gag reflex, or gag and cough reflex. So definitely these patients will be intubated and ventilated. So if you put a suction catheter inside the ET tube, and if you try to do suctioning, then the patient should cough. Actually, if you go beyond the ET tube and touch the trachea, the patient will try to cough. But in brain dead patient, that will be absent. So here comes the third part of this, which is apnea testing. So in apnea testing, there are certain important guidelines which we have to follow. So apnea is complete, cessation of this thing, breathing. If there is no breathing, that's what we say apnea. Patient doesn't breathe, it's apnea. So if patient is not breathing and the carbon dioxide is rises, this test will be positive. So what are the breathing signs for that? Patient should be in a normal blood pressure, normal temperature, fluid balance must be correct, carbon dioxide must be within 35 to 45 mg. If carbon dioxide is not in this range, then you have to try to adjust the ventilator and bring it there. And absence of hypoxia, so the oxygen level must be normal. There should not be any events of carbon dioxide like COPD. And you have to adjust the vasopressors to vasopressor and noradrenaline vasopressor. You have to adjust all those to bring the BP to 100 mmHg, more than 100 mm. And pre-oxygenate the patient for 10 minutes with 100% oxygen to achieve more than 200 mm of PaO. And reduce the ventilatory frequency to 10 beats per minute to obtain this eucapnia. Reduce the peak to 5 centimeter. And if the pulse oximeter shows an oxygen level of more than 95%, take an ABG. That will be your baseline. So in this apnea test, we have to check all these things. And if everything is okay, everything is set right, take an ABG. That ABG is an ABG, and then we are going to do something. Okay. Then we are going to disconnect the ventilator. So disconnecting the ventilator, patient is not breathing, so obviously carbon dioxide will go high. So that is the point we are going to tell here. So if the carbon dioxide goes up, definitely this test is positive. So disconnect the ventilator, give oxygen to a normal oxygen tube. Give 6 liters per minute. Give for 8 to 10 minutes. So during that time, observe the respiration also, if there is any respiration. If there is no respiration, that's fine. If there is a respiration, you have to stop the test. And if BP falls, or if the saturation falls, or if there's a severe bradycardia, then you have to stop the test. Or if the patient is okay with oxygen, wait for 8 to 10 minutes, and then do an ABG, and then connect it. Okay. So in this ABG, the carbon dioxide level should be more than 60, or from the baseline, 20 increase should be there. So that's the criteria. If that is there, then this test is positive. Apnea test is very important, and this we are going to repeat after 6 hours. The apnea test is positive, no respiratory movements. Arterial PCO2 is 60, or if increase from the baseline. If you feel this test is inconclusive, then you have to go for ancillary test. So ancillary test, what are the ancillary tests? EEG, cerebral angiography, nuclear scan, transcranial Doppler, or MRI, these things are. So next thing, important thing is documentation. So the documentation is, the time of brain death is very important. So time of brain death is indicating
Karthik?
when the ABG shows high
Karthik?
that is the time of brain death. Okay. So that has to be documented.
Karthik, voice is not clear.
What if
Karthik?
So children most commonly occurs in trauma, result of trauma, or anoxic interflow.
Karthik?
So US guidelines for intervention was updated in 2011. So diagnosis of brain death cannot be made in preterm infants less than 37 weeks of gestation. Hypotension, hypothermia, metabolic disturbance should be treated and corrected before starting testing of this. And 2 examinations, including apnea test, with each examination separated by an observation period or required. An apnea testing may be performed by the same physician. An observation period is like 24 hours for the newborns to 30 days. Like one assessment is done now and another assessment has to be done after 24 hours. And if the baby is more than 30 days to 18 years, then you have here in this apnea test children. Is my screen seen? I hope you could see it. So it should be 24 hours and 12 hours for children. Planning for each test and then we get specialist with like that. Apnea test is positive if PhD was presenting 20 the baseline from the baseline, and if it is more than 62, then it's fine. The same for the adult for the children. If the apnea test cannot be completed safely, then obviously you have to go for an test. Most of the time, you complete the apnea testing successfully. And very few times I have faced going for this ancillary testing, but it's very practically difficult when you are coordinating for an organ donation. Middle of the night, ancillary test is really have awkward. But definitely I will do for documentation. But very indicated things. So ancillary test is mainly to assist in making the diagnosis of when components of the examination
So we are talking about this ancillary test. So in this ancillary test, as I said, it is it is helping to assist the diagnosis of brain death. It is if apnea is not positive, or if you could not do it properly, then we are going to do this. So if there is any medication effect or anything, we have to remove everything, and then you have to do this test. So who is authenticated to diagnose it? So a medical administrator in charge of the hospital, authorized specialist, an authorized neurologist or neurosurgeon, and medical officer treating the patient. So these four people are included in this diagnosis. So there is a form like for brain death testing form, so certificate form. So only through that you can certify it. So in that form you can see all the name, diagnosis, everything, and then this checklist will be there. So they have to fill this checklist 6 hours apart, and then these four experts has to sign at two different times, like 6 hours apart. So in Indian context, if you see, awareness about brain death is very less. The awareness is very less, I would say. So people are not aware of brain death and organ donation. So previously, before COVID, we go to colleges, and we speak a lot about this to the students, assuming they will take it to their parents or relatives, and when something happens like this in their context, they will accept this brain death, and they will go for organ donation. So various aspects of brain death, its importance for organ donation and its legality need to be elaborated. People doesn't know the legality involved in this. The very poor thing in our country is even the physician, even the doctors doesn't know what are the legal things involved in this. So they doesn't want to do it actually. So even though they identify brain death, so they just say patient is death, you can take home. So this is what happening in a lot of places. So we try counseling doctors initially before patient, so to identify brain death and to inform the relatives. So the choice has to be given to the relatives. So that is our important thing to do it. So in India, the Transplantation of Human Organ Act was passed by Indian Parliament in 1994, which legalized brain death. So before that, there was no legalization. So only after this, made all these attempts to do this brain death certification. So highlights of this act are statutory sanction to the brain death concept, regulation of removal, storage, and transplantation of human organs for therapeutic purpose, and commercial dealings in organ harvesting is prevented. So you could see in many films. So this people getting downtrodden people from villages, and they remove their kidney. So இதெல்லாம் முன்னாடி நடந்திருக்கு ஆக்சுவலா, லாங் பேக் இதெல்லாம் நடந்திருக்கு. இப்பவும் ஸ்டில் ஐ கெட் ஃபோன் கால்ஸ் ஆஸ்கிங், ஸோ இந்த மாதிரி நான் கொடுக்கலாமா, கிட்னி கொடுக்கலாமா, நான் கிட்னியை கொடுக்குறேன். ஸோ தட்ஸ் ஆல் நாட் லீகல் ஆக்சுவலி. ஸோ கிட்னி கொடுக்கலாம், ஃபார் whom you have to be related to the recipient, okay, in live donation and all. So after this act came only, these regulations came into practice, and these have been prevented. So none of the doctors who participate in the diagnosis of brain death should have interest in transplantation of organ removal or organ removal. So some doctor is involved in transplant should not do this, and he is not allowed to diagnose brain death. So why there is a reluctance to accept brain death? So lack of understanding. So years together, we are seeing only the normal death.
A normal death in the sense only when the heart stops or there is no respiration, we say death. And suddenly, if we say this, there is something called brain death. People cannot accept actually. So we should make people understand there is something like this. We should counsel them in correct way to accept it. And special emotions attachment to the dead person. So when there is a lot of emotions involved, maybe the injured person as a son or daughter or mother, or so in this emotional context also they cannot accept. So they'll think patient is still alive, because when we see the monitor, you can see the ECG running, and we can see the respiration showing some values. So by seeing all those, people will not believe that this patient this person is dead. Okay. And loss of confidence in medical practice. So in general, we think that what we say, people will do in the medical field. Patients will do, patient will follow. But that is not right actually. People still have a lot of doubt on us, and people go for second opinion, and people go for some alternative practice and everything. Still there is no right belief. Probably munadi irundhan therilla, now this belief and all is coming down a lot. And ethical questions related to earlier organ transplant procedure. So they would have heard all this organ racketing, which means organ திருடுறாங்க. So இந்த மாதிரி நியூஸ் எல்லாம் ஒரு இடத்துல கேட்டிருப்பாங்க. So because of that, even there will be a reluctance to accept. Okay. And perceived insufficient participation of government and medical association. Now government is kind of participating a lot in this. But all these are off late, maybe for the past 5-6 years. Government is very much active, and Tamil Nadu government is very active. So we have an registry called the TNOS. So TNOS is very much active into it. So this is an interesting thing I came across while preparing. So this is an Lazarus sign. I have never known this actually. Recently when I read something for this preparation, I saw this. But clinically, I have something correlating to this I have seen. So this is a biblical character. Jesus restored Lazarus to life 4 days after his death. So this is what they say, or the Lazarus reflex. So in brainstem death patient, I have seen something like after diagnosing brain death, I have seen there is some jerky movements in the hand and legs. Okay. So that is actually that is because of that there is a movement. So if patient attenders see that, so they'll definitely refuse to believe that there is this is brain death. Okay. So in this they are specifically they are saying that raise their arms and drop them across the chest. This I have not seen, but something related to this, maybe the jerky movements, but this is interesting slide, Lazarus sign. Maybe you can notice, you can if you come across any brain dead patient, just check on this. So what is the role of nurse in this? Why we have to know about this brain death and identifying the reflexes, everything? To my thing, as I said, the physicians are very reluctant. So why? Because actually or a valid reason என்னன்னு பாத்தீங்கன்னா, patient comes for the name of the physician. In few places patient come for the hospital. So when patient come for the name of physician doesn't want to lose the patient. So he will think that my name will spoil, and the hospital think that hospital reputation will spoil if you diagnose brain death. This is a concept prevailing even in Tamil Nadu. I have seen that. Okay. So a nurse should be there to initiate this process. So nurse, we are in the bedside all the time. So by knowing all these reflexes, apnea testing, and why we need to identify brain death and everything. So we will have the knowledge why we should identify this. So early detection of brain death, we will be able to do before the physician. Okay. So second one is the identification of reflexes. So reflexes, that is very easy. You can identify all those reflexes which I listed out, and assisting in determination process, maybe the apnea testing or ancillary testing. So everything, without a nurse, there is nothing going to happen. And most of the places abroad, I'm saying, nurses are the transplant coordinators. But in India, medical social workers are transplant coordinators. But they will not have much knowledge about all this. Few people, senior people have. Juniors, they won't have. But if there is a nurse in that place, definitely we will be able to do this, very rightly. And next is the documentation. Documentation is very important. As I said, to take care of that forms signed by the 4 doctors and proper seal and everything, and in your charts, if somebody puts a case after a few years, only our documentation will talk. Okay, so documentation is very important, and proper communication. So communication in the sense, communication to attenders, communication to the family is very important. So I can give you a lot of examples where when communication fails, there are problems. So here it's in this hospital where I'm working. So I used to say all the ICU doctors and nurses keep communicating to the patient attenders. So even if there is problem from our side also, if there is communication is right, they will accept it, and they'll go on. But if the communication is not right, then we are sued. Also, only when there is proper communication, people will understand there is something brain dead and all. And psychological support. So it will be devastating for the family to hear something like this. So you should give a proper psychological support to the family. And this is a time where you have to initiate for organ donation counseling. If the patient is accepting, brain death is there, so our loved one is brain dead. So you can counsel them for organ donation. You can start with the eyes and then go on for the other organs counseling. So common misconception. What will be the common misconception I have come across is, so there is an heartbeat, so he's alive. That's what people think, as I said in the previous slide. So in this, so here nurse has to explain a lot to the patient attender. Okay, you have to explain why the heart is still beating, how the respiration is happening. So respiration we are giving, the patient is not breathing, we are giving the respiration. So that we have to make them understand. And they'll say he's in coma, so he's sleeping. So that is not the case. In coma, there will be some reflexes. Patient will be breathing. The brainstem will not be gone completely. But in this case, it is not coma, it is brain dead. And the patient is dead. He is not going to come back. The brain had an irreversible damage. Okay, so that you have to emphasize. If you pull out the ventilator, the respiration center is already gone. So he will not breathe and he will die. That you have to tell them properly. And other thing, they'll say if we do a rehab, he can become better, and that also proper counseling is required. That is not going. The patient will not come out because brain has an irreversible damage. And how to make it clear to attenders. That's what I'm mentioning here. So say dead, not brain dead. Okay. So if you tell the word brain dead to attender, patient relatives, so they'll think, okay, brain is dead, the other parts will be functioning. So don't tell that. So tell that always while talking to the patient relatives who are brain dead, or tell them your relatives are either loved one is dead. Okay, and this say artificial or mechanical ventilation, not life support. So he's brain dead, so brain is not functioning. So the other respiration and heart won't function, and we are supporting it. That's what we have to tell. And time of death is the neurological determination, not when the ventilator is removed or not when the heartbeat stops. Okay, and don't say kept alive for organ donation. So that also they can't accept. They'll misinterpret. They'll take it in a wrong manner. And do not talk to the patient as if he is alive. So we should make them understand patient is dead and he will not come out of this. So that is a way you have to communicate. So in this organ donation, brain death, all these are very, very what to say, where we have to be very careful. Okay, now media is everywhere, so you don't know who is there in media. Like they doesn't want even a big camera. Now every mobile is there. They put a camera in their pocket and they come and they'll talk to you, get something from your mouth and they'll publish it. So this all happened. Recently, it happened to one transplant coordinator. So we should not talk anything apart from this, because the main thing they'll ask is for organ donation, will the hospital give some money? So if that thing happens, that will become a business. So people will try to ask all these kind of questions. So you should be very careful in the legal aspect. So you should have all these form for brain death certification, form for consent of organ donation, proper documentation must be there. So if all these things are there, then you are safe from a legal point of view, and you know how to diagnose brain death. So if these two clinical and legal aspects are maintained properly, this can be a good success. So conclusion, attention must be given to understanding the public and professional perception of brain death, to educate both groups, and proper laws should be formulated. Still there are some holes in the law, like so brain death declaration should be only for organ donation or for everyone. Actually, government has said for everyone the brain death declaration should be done. But can we pull out the ventilator even if the patient is not agreeing for organ donation, is again a question. Okay, that is not fulfilled still. So proper law should come and proper awareness should be there. Then this brain death and organ donation will be a great success. Tamil Nadu is leading in this organ donation. For that, we should be proud of, and we should take it forward actually. So thank you. I could not hear actually. I could not hear.
Now? Yes,
Yeah, no, I
thank you,
can.
Karthik.
Sorry, there was a lot of voice problem.
Yes, repeatedly I made a call. It's okay, but it's a good content you have. You took.
Is it all received properly? Actually,
Yes, definitely. My student will follow. Okay, beginningly you about your clinical experience in PSG. That is a thing my students want to know. They should not spend a time during their clinical time. So they should know what is PSG. So that from that view, I'm happy that then we can read the theory from anywhere. But you have shared many aspects in legal thing, your experience. That is the thing. It's very useful for us. You shared the Lazarus sign. So we read, we have seen in book, but I also not seen from the patient side. It's a good. Anything else you want to share?
Nothing. Any questions from student side? Students are there still there?
Side. So the mic is not functioning. That is the problem.
Okay. They can hear what we are talking.
Yes. They are listening. So thanks for accepting for this session.
Thank you.
ஓகே
Thank you.
வேண்டாம். தேங்க்யூ தேங்க்யூ. நான் போறேன். பாதி சவுண்டே கேட்கல. ஃபோன்ல இருந்து எடுக்கணும் இருக்கு. கார்த்திக் நீங்க எடுத்துக்கோங்க. கார்த்திக் இந்த பண்ணலையா?
உங்களோட வாட்ஸ்அப் வெப் ஓபன் பண்ணுங்க.
ஓகே. மைக் ஆன் பண்ணா எடுக்காது மேடம். மைக் ஆன் பண்ண வேண்டாம். மைக் ஆன் பண்ண வேண்டாம் மேடம்.
உங்களோட வாட்ஸ்அப் வெப் ஓபன் பண்ணுங்க. நம்ம அப்பதான் இது காப்பி பண்ணோம்ல யூடியூப் லிங்க்.
அது கேட்டுட்டு இல்ல நான் ஆரம்பிக்க ஃபோன் பண்ணி சொன்னேன். என்னோட ஃபர்ஸ்ட் ப்ரீவியஸ் செக்ஷன் முடிஞ்சிருச்சு. வந்து மைக்ல தான் ப்ராப்ளம், அதனால லேட் ஆயிடுச்சுன்னு. நான் ஸ்டார்ட் ரெக்கார்டிங் முடிச்சுன்னு ஸ்டார்ட் பண்ண போறேன்னு சொன்னேன். நெக்ஸ்ட் உங்களுக்கு 11:30 பார்த்துக்கோங்க. நாங்கள் சீக்கிரம் முடிக்க பார்க்குறேன்னு சொல்லி முடிச்சுட்டேன்.
ஜாயின் ஆகல, ஃபோன் பண்ணி கேட்கணும்.
சரி நம்ம ஸ்டூடெண்ட்ஸ் கிளாஸ் ரூம்ல இருக்கும் சொல்லு.
உங்க கிளாஸ் ரூம்ல
யாருக்கு
அனுப்புறது? உனக்கே போட்டுக்குமா? டி போடு. திவ்யா ப்ளீஸ். தேங்க்யூ தான் செல்லம்.
யூடியூப் லிங்க் அவ்வளவுதான்.
ஓகே நான் பாதி கேட்டிருக்கேன்.
சைன் அவுட் பண்ணிடுறேன். இப்போ உங்களுக்கு ஓபன் பண்ணி
ரெக்கார்ட் பண்ணி வச்சுக்குமா? நான் போறேன்.